eye to eye with thyroid eye disease.
How autoimmune thyroid disorders affect the eye. Hi, Dr. Charles Soparker again. Welcome to PESA Productions' 6th video section on thyroid eye disease. In this section, we review the clinical features of thyroid eye disease, the eye signs and symptoms people might experience. It is important to remember 3 things in this section. First, we must remain deeply grateful to the people who have allowed us to share their photographs so that others may learn. Second, many conditions are shown in this section that represent extreme examples in order to clearly demonstrate the eye changes. Most people never reach these levels of eye change. Finally, almost all eye changes are treatable or reversible. In the over 7,000 patients personally treated with this disorder, nobody has gone blind in our practice. Vision loss is not a foregone conclusion. It made sense to us to keep all of this section in one video, which has made this particular video the longest in the whole series. If you want to review a particular part of this video, there's an outline that will repeatedly appear that can be used as a guide to find the part that interests you. The material in this series is meant to be easily understood. Parts, however, may be somewhat dense, and you may wish to review particular sections. If you have suggestions on how to improve this series, we welcome your comments. You may find us on the web at www.plasticeyesurgery.com, email us at info@pesahouston.com, write to us at Plastic Eye Surgery Associates, 3730 Kirby Drive, Suite 900, Houston, Texas 77098, or telephone us at 713-795-0705. The clinical eye features, the things a person sees and feels, are covered in the subsequent videos in this section. We will discuss why eyes feel dry and water, what makes the eyes red, glaucoma, eyelid retraction, weak, blink, and poor eyelid closure, droopy eyelids, swelling on the surface of the eye called chemosis, eyelid swelling, eye movement problems called ocular dysmotility, bulging eyes, optic nerve injury called optic neuropathy. Throughout these videos, we may use the terms signs and symptoms. A sign is something that someone else can see or discern about an affected individual, whereas a symptom is something the affected individual personally experiences. For example, a red eye is a sign that anyone can see, whereas eye irritation is a symptom that only the affected person can feel. We'll start by discussing the most common and often the earliest symptom of thyroid eye disease, dry eyes. Although dry eyes are usually the first symptom, and often the changes caused by dry eye on the surface of the eye may be the first sign seen under a slit lamp examination by an eye doctor, dry eyes are one of the least specific findings in thyroid eye disease. Lots of things may cause a dry eye. The eye must always be kept lubricated in order to keep it safe and healthy, so our body makes tears all the time. The tears are produced by a number of different types of glands, and then the tears are actively pumped by our blinking eyelids down a pair of microscopic tear drains into the back of our nose and throat, which is why when we cry, often our nose runs. It's also important to understand that a dry eye is not necessarily an eye with just low tear production. Any problem with either the tear quality or the tear quantity will produce tears insufficient for eye protection, and we in the medical community often call all of these problems dry eye. As we've said, the eyes must be constantly lubricated. If they are not, severe cases can not only be extremely painful, but they can also be extremely dangerous for the eye. If you wish to know more about the complexity of dry eye problems or the management thereof, our website contains a video on different types of dry eye problems and an excellent resource called Mastering Tear Supplements. An interesting paradox is that a dry eye often presents as an eye that is constantly tearing. Anything that causes eye irritation will cause excessive tearing. This includes tear quality problems. So someone with thyroid eye disease may actually first complain of constantly watering eyes even though they are having a dry eye problem. There are several reasons for a dry eye problem developing in someone with thyroid eye disease that potentially, but not always, leads to increased tearing. The first is decreased tear production. Cells within some of the complex tear-producing glands are targeted by the autoimmune antibodies in thyroid eye disease. In particular, the lacrimal acinar cells in the major tear gland, called the lacrimal gland, have TSH receptors to which some of the autoimmune antibodies may bind. Binding of the autoimmune antibodies can lead to localized inflammation, scarring, and eventual destruction of these tear-producing glands. Not only is there decreased tear production, but there is also decreased tear quality, with decreased tear stability, which leads to increased tear breakdown and increased tear evaporation. This is caused by increased inflammation in the eyelid and eye area, for the reasons we've previously discussed in video sections 2 and 4. The third reason for a dry eye in thyroid eye disease is increased eye surface area exposure, and thus increased tear evaporation. This happens because of increased eye bulging, called proptosis. The farther forward or more protruding, sticking out of the eyes, the more they are exposed to air blowing across them, which increases the rate of tear evaporation, causing dry eye. Upper eyelid retraction is the position of the upper eyelid too far upward, and lower eyelid retraction is the position of the lower eyelid too far downward. Both of these serve to increase the distance between the upper and lower eyelids, increasing the surface area of the eye available for tear evaporation and creating a dry eye problem. Lagophthalmos is an inability for the eyelids to fully close, which allows continued tear evaporation during normal blinking and while the eyes are presumably closed. Blinking is also affected in thyroid eye disease. Eyelid blinking is like a reverse windshield wiper that wets the eye with every blink. In thyroid eye disease, there is often an incomplete blink, since the eyelids may be stiff or scarred, and there can be less frequent blinking. All of these issues contribute to the dry eye problems in thyroid eye disease. Now, not everyone with dry eye has thyroid eye disease, but most people with thyroid eye disease have dry eye. Red eyes are another frequent complaint of people with thyroid eye disease. In fact, thyroid eye disease is often initially misdiagnosed by professionals and lay people alike as eye allergy. A clue to when thyroid eye disease actually began may be when a person starts taking eye drops, as in drops to take out the red, as eye redness and irritation are commonly two of the earliest manifestations of thyroid eye disease following dry eye. As we mentioned in section 5, the blood vessels around the eyes become more dilated with a larger diameter, and they also get more leaky, causing local swelling. In particular, the so-called anterior ciliary arteries on the eye surface become more swollen and enlarged. These vessels cause a red eye appearance in the horizontal meridian, that is along a horizontal line through the middle of the eye. Note the relative sparing of the superior and inferior poles of the eye, with relative whiteness above and below the cornea. If the eyelids are not pulled apart, as they are here, and the eyelids are lying naturally against the eye, at first glance it would appear that the whole eye is red, because the parts that are not red are hidden behind the upper and lower eyelids. As we've said, these enlarged blood vessels are also fairly leaky, allowing the fluid component of blood to leak into the local tissues. If one looks carefully near the dilated vessels, one can appreciate a pinkish or yellowish hue reflecting swelling, or so-called edema, in these areas. Edema specific to the surface of the eye is called chemosis, but we'll discuss more about that later. Like all aspects of thyroid eye disease, different people may show different degrees of vessel dilation and localized edema or swelling, but such blood vessel enlargement characteristically occurs in the horizontal meridian. For every rule, there is an exception. There is a condition known as SLK, or superior limbic keratoconjunctivitis, that will cause redness in the area just above the colored portion of the eye. Although relatively uncommon, SLK does occur in association with thyroid eye disease, So in rare cases, the eye may be red across the middle and across the top, but not under the lower eyelid. And since there is an exception to every rule, there is an exception to the exception to the rule. Some people with thyroid eye disease are also troubled about their red eyes, and they're so troubled that they start using ophthalmic decongestants. That is, over-the-counter drops that are meant to take the red out. Even though these medications are non-prescription, the frequent or chronic use of such drops can be very problematic and should be avoided unless specifically physician-directed. One of the conditions that may develop is called medicamentosa toxicum, a toxic allergic reaction to a number of the ingredients in the medications. So in such cases, someone with thyroid eye disease may develop redness over the entire eye. But accepting the exceptions, thyroid eye disease causes redness mainly across the middle of the eye. Glaucoma may also be seen in people with thyroid eye disease. It is not as common as other eye findings, but it may be a silent blinder in this disorder if not remembered. Glaucoma is caused by pressure inside the eye that is higher than the optic nerve can handle. One may have high pressure in the eye for a long time without developing any optic nerve damage, and many physicians would call this ocular hypertension. Conversely, one may have normal or relatively low pressure in the eyes and still have optic nerve damage, so-called normotensive or low-tension glaucoma. Most forms of glaucoma are totally painless, slowly robbing the eye of vision through damaging the optic nerve. That's the nerve that carries vision signals from the eye to the brain. As glaucoma progresses, the front of the optic nerve becomes more hollowed out. This picture shows a small part of the back of the eye where the optic nerve enters the eye. The outer edge of the optic nerve is the large ovoid shape. If you look carefully at the smaller blood vessels, you can see them make a sharp turn at the edge of what is called the optic cup. The optic cup is a paler ovoid shape and plunges down into the middle of the optic nerve. The optic cup is the absence of nerve fibers. It is normal to have some cup, but as the optic nerve dies from pressures that are higher than it can handle, the cup becomes larger and larger, decreasing peripheral vision until eventually, if untreated, there is no more nerve and no more vision. That is why people who are suspected to have glaucoma get visual field tests and optic nerve assessments on a regular basis. People with thyroid eye disease seem to have an increased risk for glaucoma. We'll pass on discussing the theories on why this is so. However, in addition to having a greater chance of getting glaucoma, people with thyroid eye disease often have significant ocular hypertension, especially when looking in a particular direction. Ocular hypertension, or very high eye pressures without optic nerve damage, is not thought to be dangerous, but warrants close observation to be sure glaucoma does not develop. There are several reasons why ocular hypertension frequently develops in people with thyroid eye disease. First, the eyelids become more rigid. Second, there is increased fat and muscle volume behind the eyes. The eye is then squashed between the rigid eyelids and the increasing volume and the pressure in the eye socket. This increased pressure on the eye translates to increased pressure within the eye. In addition, swelling and subsequent scarring of the muscles that move the eyes may cause pulling pressure on the eye, raising pressures within the eye, especially in certain gaze positions, whenever the eye tries to move away from a scarred muscle pulling on it. We call this gaze positional ocular hypertension. For these reasons, whenever a diagnosis of thyroid eye disease is made, a person should have their eye pressure checked at a regular interval, at least every 6 months during an active phase of the disease. Eyelid retraction is a critical part of thyroid eye disease because it is eyelid retraction that is responsible for the 3 signs that are most characteristic of thyroid eye disease, signs that help us to make the clinical diagnosis. Remember, the diagnosis of thyroid eye disease is based upon physician observation, not on any blood or X-ray studies. There are very few things other than thyroid eye disease that can produce these 3 signs. More about these 3 signs in just a few minutes. Once you know what to look for, eyelid retraction will become very obvious. Upper eyelid retraction is an increased upward distance of the upper eyelid from the center of the eye. Note the increased exposure of the white part of the eye just above the colored part of the eye. This is upper eyelid retraction. This is lower eyelid retraction, with an increased distance of the lower eyelids below the center part of the eye, creating an increased exposure of the white part of the eye below the colored part of the eye. Here the eyelids are returned to their natural position. But even in the natural position, you can perceive a hint of upper and lower eyelid retraction towards the lateral or ear side of the eyes. Note how much more white is showing on the outer edge of the eyes compared to the inner edge. There are characteristic hallmarks of thyroid eye disease. Eyelid retraction is caused by inflammation and then scarring of the muscles that raise the upper eyelids and those that lower the lower eyelids. It is this change in the muscles that accounts for the 3 early signs of thyroid eye disease, which are so specific that we say that they are the hallmarks of the disease. The 3 signs are lateral flare, upper eyelid elevation upon excitation, and von Graeffe's sign. Let's explain the first. That's lateral flare. This young woman has thyroid eye disease. Her left eye, the one on your right, is fairly normal with the upper and lower eyelids covering at least a small part of the colored part of the eye. With experience, you will recognize that the upper eyelid shape is not quite right, but is close enough for us to call it normal in this case. Note the nice curve of the upper eyelid. Normally, the peak of the curve should be about the midpoint of the eye or slightly on the medial or nose side. The right eye, however, on the left side of the photograph, shows upper eyelid retraction with lots of white showing above the colored part of the eye. The shape of the upper eyelid is also different from the other side. The right upper eyelid is actually somewhat flat. Notice that although this is a systemic disease, the 2 eyes are not equally affected. Thyroid eye disease is always bilateral, affecting both sides, but it is commonly asymmetric. That is, the 2 eyes are often affected to different degrees. We call this lateral flare because the outer edge of the eyelid, so-called the lateral side, flares upward more than the rest of the eyelid. In an eye with less obvious upper eyelid retraction, this also contributes to the appearance of more white showing on the outer side of the eye. The second sign, upper eyelid elevation on excitation, is pretty much what it sounds like. As a person is speaking and becomes slightly excited or animated, the upper eyelid will often pop up and down intermittently, showing white above the colored part of the eye. The third and final characteristic sign is von Graeffe's sign, named after the physician who first described it. Normally, when the eye moves downward, say to read a book or walk downstairs, the upper eyelid tracks smoothly downward, keeping pace with the eye. In von Graeffe's sign, the upper eyelid hangs up for a moment and then follows the eye. This is easily seen as a momentary increase in the amount of white showing above the colored part of the eye. Reverse von Graeffe's sign, also known as Coker's sign, occurs when a person looks upward and the upper eyelid jumps up ahead of the eye, again briefly showing white above the colored part of the eye. Watch the following video segment and see if you can pick up von Graeffe's sign in the woman's left eye. The video will run again in slow motion if you missed the first time. What are the causes of eyelid retraction? We said before that the reason that the eyelid retraction occurs is that the muscles that move the upper eyelid upward and the lower eyelid downward become scarred and shortened. Although this is certainly true, the story is, of course, much more complicated. Suffice it to say that eyelid retraction is a complex multifactorial problem caused by many different tissues around the eye, all of which carry TSH receptors and may be affected by autoimmune antibodies. Correction of eyelid retraction often requires resolution of many of these issues. Continued release of certain chemicals in the blood that occurs with elevated thyroid hormone levels, as seen in hyperthyroidism, may create eyelid retraction. But it is important to realize that this eyelid retraction is not really the same as thyroid eye disease, because as soon as the thyroid hormone levels normalize, the eyelid retraction vanishes. In thyroid eye disease, however, the changes do not change with changes in thyroid hormone levels, and careful examination will reveal the underlying scarring pathology. But once again, it is easy to see how someone might confuse the relationship between thyroid disorders and thyroid eye disease, because in the presence of high thyroid, temporary eyelid retraction may appear very much like thyroid eye disease. Thyroid eye disease may take on several different appearances. In this case, this young woman has upper eyelid retraction in both eyes. Note the greater lateral flare in her right eye. There is minimal lower eyelid retraction. This young man, on the other hand, has lower eyelid retraction on both sides without any upper eyelid retraction. Thyroid eye disease may be subtle. As we've said before, different people develop different degrees of disorder. 1 out of 5 women who come into our practice for cosmetic consultation have unrecognized thyroid eye disease. Can you spot the subtle lateral flare and upper eyelid flattening on the right side in this attractive woman? Now look carefully, and you might recognize the dilation of her anterior ciliary arteries, more on her right than her left, in the horizontal meridian in her eyes. Observing these 3 signs will often pick up early thyroid eye disease. It is very important to carefully examine the eyelids before performing any cosmetic eye surgery. This lovely lady wanted to have cosmetic eyelid surgery, so-called blepharoplasty surgery, but on examination we found evidence of von Graeff's sign. We suggested she wait a bit and return to see if other signs of thyroid eye disease developed, because if we operate during an active phase of thyroid eye disease, 2 things may happen. First, her eyelids may continue to change, and so we may have to operate again. Second, thyroid eye disease is an autoimmune disease driven by the body's inflammatory cells. A good way to really turn these cells on into an active phase is to create surgical trauma. Instead, we prefer to wait until the disease is quiet. Since her thyroid hormone blood levels were normal, and she had none of the 3 commercially available autoimmune antibodies detectable, she and her primary physician were skeptical of her diagnosis. 2 months later, her eyelid retraction and lateral flare were a little bit more apparent. Another 3 months, a total of 5 months after her initial visit to us, and nobody questioned the diagnosis. Here's another young woman whom you've already seen, who also wanted a blepharoplasty surgery. Already we can see the subtle signs of eyelid retraction and lateral flare with a hint of dilation of her ciliary arteries in the horizontal axis. Surgery was deferred for at least 3 months. 3 months later, her thyroid eye disease is very apparent. Another woman came to see us for cosmetic surgery, and now the signs are clear. Even in this still photograph, the upper eyelids are up at the top of the colored part of the eye, already showing a little tendency to retraction. Lateral flare is apparent, and note the redness of her eyes across the horizontal axis. The lateral flare, upper eyelid retraction on excitation, von Graeff's sign, and anterior ciliary artery dilation prompted us to delay this woman's cosmetic surgery. Again, all her blood work was normal, and her primary care physician doubted the diagnosis. 5 months later, her thyroid eye disease has blossomed. Here's one more example. This woman has normal upper eyelid shape resting at the very upper edge of normal, just tangent to the colored part of the eye. Her lower eyelids, however, show clear retraction. Eyelid retraction in thyroid eye disease may affect one eyelid or all 4. It may be subtle or obvious, but when we look for it, we find that eyelid retraction is one of the most reliable and earliest signs of thyroid eye disease. After our examination, her thyroid hormone levels were found to be high, and she was treated by an endocrinologist. You can see that her thyroid eye disease progressed over the ensuing 6 months. At this point, you may be wondering about a couple of things. Once a diagnosis of thyroid eye disease is made, does everyone progress, and do they do so as quickly as we've shown over just a few months? The answer is no to both of these questions. Not everyone progresses to extreme degrees, and the duration of change can be anywhere from 2 weeks to 5 years. More about this in the next section, section 7. You may also be wondering, if we can recognize the disease at fairly early stages, why don't we stop thyroid eye disease before it progresses? In section 8, we cover the management of thyroid eye disease, and this question will become answered at that time. Another manifestation of thyroid eye disease is weak eyelid closure, or a weak blink. This happens for several reasons, but mostly because of the scarification of the muscles that both close the eyelids as well as those that open them. Weak eyelid closure leads to the lag ophthalmos, which is the inability for the eyes to close completely. The term comes from the Greek word lagos, which means hare. You know, the animal that is like a rabbit but larger. It was erroneously believed that hares slept with their eyes open, and so someone whose eyes don't close all the way, without forced squeezing, is said to have lag ophthalmos, because their eyes don't close all the way when they sleep. A small amount of lag ophthalmos is relatively common in the general population, but more severe lag ophthalmos associated with thyroid eye disease may result in severe eye drying at night or incomplete blinking closure during the day. This person is trying to close her eyes, as we can see by the eyeballs rolled upward, but the upper and lower eyelids don't meet. The yellow around her eyes is from colored eye drops that were used during her examination and don't represent disease. Again, in this man, he is attempting to close his eye, but the eyelids don't fully meet. Eye closing muscle weakness may be due to scarring, but as we know, thyroid eye disease is an autoimmune disorder, and once people get one autoimmune disorder, they are likely to have others. Another autoimmune disorder called myasthenia causes a problem with the motor nerves that tell the muscles to contract. One may conceptualize the situation as the motor nerve needs to shoot a rubber pellet at the muscle, encouraging it to move. In myasthenia, the nerve is not able to reload quickly, so it fires successfully at first, but repeated firings throughout the day are less and less successful. Myasthenia may cause other muscle weaknesses around the eye as well. Lag ophthalmos in thyroid eye disease is usually due to an abnormality in upper eyelid function from closing muscle weakness or opening muscle inflammation, scarring, or overaction. But lower eyelid abnormalities such as eyelid retraction may play a role as well. In this young woman, one can see that lower eyelid retraction or scarification of the opening muscles of the lower eyelids plays a significant role in her lag ophthalmos. Lag ophthalmos, where the colored part of the eye is exposed, may result in severe eye drying, but in people who have had lag ophthalmos their entire life, it is well tolerated. In others, even lag ophthalmos, where the colored part of the eye is not exposed, can cause intolerable eye drying. Thus, like everything else in thyroid eye disease, different people have different degrees of disease expression and different degrees of tissue acceptance and personal comfort. The orbicularis is the muscle that closes the eye. When both the upper and lower eyelid orbicularis muscles are involved with inflammatory infiltration and scarring, there is some degree of eye bulging. The eye exposure and eye drying can be profound. This nice lady is trying hard to close her eye, but the best she can do is roll her eye back up under her eyelid. Upper eyelid droop, the opposite of upper eyelid retraction, is more formally known as blepharoptosis. The word blepharoptosis comes from blepharo, meaning eyelid in Greek, and ptosis meaning falling, so a falling or droopy eyelid. Often blepharoptosis is shortened in both conversation and writing to just ptosis with a silent P. There are many different types of eyelid ptosis and many causes, but here we will focus on the most commonly associated with thyroid eye disease. In general, it is much more common to see eyelid retraction in thyroid eye disease than blepharoptosis. But in people without thyroid eye disease, blepharoptosis is far more common than eyelid retraction, which is why the signs based upon eyelid retraction are key to making the diagnosis of thyroid eye disease. A frequent cause of droopy eyelid in thyroid eye disease is so-called pseudotosis or fake ptosis or secondary ptosis. All three of the people shown here were sent to us to repair their droopy upper eyelid. But in all cases, The retracted upper eyelid on the other side was the primary problem. The two upper eyelids behave sort of as though they were on a seesaw. When one upper eyelid goes up, the other often goes down. When an eyelid goes down, the other often goes up. This phenomenon is said to be an example of Hering's law, spelled like the fish but named after a physician, not the expression red herring, which, by the way, also sort of applies. The following video demonstrates Hering's law. Notice that raising the eyebrow has an effect on dropping the opposite eyebrow, as well as the eyelid. However, raising an eyelid has an even more dramatic effect on dropping the contralateral upper eyelid. This is even more pronounced on the right eye because the right eye is his dominant eye. So all three of these people had upper eyelid retraction from unrecognized thyroid eye disease, causing a Hering's law effect with ptosis of the contralateral upper eyelid. Surgical correction of the upper eyelid retraction in all three patients effectively corrected the pseudotosis, because by lowering the retracted eyelid, the other eyelid rose. This is a truly droopy eyelid without contralateral upper eyelid retraction. With chronic or repeated eyelid swelling from thyroid eye disease, the muscle that raises the eyelid may become detached from the skeleton within the eyelid where it normally inserts. This effectively lengthens the eyelid muscle and lowers the eyelid height. Reattachment of the muscle to the eyelid is usually required. Here is a young man with bilateral ptosis, i.e. droopy eyelids on both sides. The so-called ptosis is not strictly due to thyroid eye disease itself, but to myasthenia gravis, another autoimmune disorder that we've already discussed, which may sometimes be found in conjunction with thyroid eye disease. Here is a young woman with severe hypothyroidism, or low levels of circulating thyroid hormone. Notice the large goiter or swelling of her thyroid gland in her neck. She has profound fatigue and clearly droopy eyelids. Here she is shown just after 3 weeks of thyroid hormone replacement. Now with her thyroid hormone levels normalized, she demonstrates classic eyelid retraction of all 4 eyelids that we usually associate with thyroid eye disease. But wait a minute. We've said many times that thyroid hormone levels don't impact the changes seen in the eyes. So how is it that thyroid hormone normalization changed this woman's eyes from droopy to retracted? The answer, of course, is a little complicated. Although changes in thyroid hormone level don't have a direct impact on thyroid eye disease, there may be some very indirect effects through changing levels of TSH. But even that is not what's happening here. Thyroid hormone levels affect other hormones in the body. One of these hormones can stimulate certain muscles within the eyelids, making the eyelids flare open, essentially creating temporary eyelid retraction. In the absence of this other hormone, and in a depressed, somnolent state of severe hypothyroidism, the eyelids may appear droopy. Too much thyroid hormone can produce too much of this other hormone and create a situation that looks like thyroid eye disease. This is one of the reasons that so many physicians believe that thyroid eye disease is caused by the thyroid, because too much thyroid hormone can look a little bit like thyroid eye disease. So if the effects of abnormal thyroid hormone levels can look like thyroid eye disease, how can we tell thyroid eye disease and autoimmune thyroid disorder apart? There are many differences between the two, some quite subtle and others obvious. For example, thyroid hormone abnormalities don't truly make an eye bulge forward or enlarge the extraocular muscles, whereas thyroid eye disease can do both of these things. Also, thyroid eye disease causes permanent changes to tissues, whereas thyroid hormone abnormalities don't. The changes created by the thyroid hormones are temporary. As we keep seeing, nothing is ever quite as simple as it first seems. Here is an essential point. We've said that we should think about thyroid eye disease as being independent of the changes in the thyroid hormone levels, and that remains an excellent working model for treatment purposes. Nevertheless, for some people, an increase in TSH may increase thyroid eye disease severity. Not in a direct linear fashion, but in some oblique manner. We can make some guesses about how this might happen. For example, if there are a number of stimulating anti-TSH receptor antibodies in the blood, increasing the level of TSH may add to the stimulation of those receptors. Conversely, if there are inhibitory anti-TSH antibodies, a high TSH may compete with antibody binding and diminish the thyroid eye disease effects. Therefore, in complicated cases, your physician and you may wish to track whether or not your TSH level has an impact upon your particular disorder. Also, changes in thyroid hormone levels may look very much like thyroid eye disease, mimicking thyroid eye disease. Very careful observation may be needed to figure out what is thyroid eye disease and what is due to changes in thyroid hormone level. High thyroid hormone levels may cause a temporary eyelid retraction.